afternoon. I'm Carol Newcomb-Aludo, a member of the CMC's Board of Trustees. It's great to see everyone here today. This is such an important topic. Today's forum, Infant Mortality Task Force, is part of our Healthy Community series, presented by Ohio Health with support from Porter Wright, Morris, and Arthur, and with support for this forum from the Women's Fund of Central Ohio. We also want to thank National Church Residences for sponsoring all of our June forums, Pulling at the Roots of Poverty. Please help me thank again all of our sponsors. Our speakers represent a diversity of backgrounds and perspectives on the challenge of infant mortality in our community. Andy Ginther, President of Columbus City Council, will host and moderate the conversation today. Joining him as panelists are Sharon Davies. She's the Executive Director of the Kirwan Institute at OSU, Teresa Long, Columbus Health Commissioner, and Arthur James is a pediatric expert at Nationwide Children's Hospital. Andy, the podium is all yours.
Thank you so much for having us here today, and we appreciate, Carol, your generous introduction. Excited to be here today to share some initial insights and perspectives around the issue of infant mortality and the Infant Mortality Task Force. I'll just share a couple of comments with you and get right to some questions for our esteemed panelists. But one of the things that has shocked me so much as I begin to study and better understand the issues contributing to our crisis, because it is a crisis in this community, that 3 infants die every week in this community, in Franklin County, 150 children a year before their first birthday. This issue, Dr. James and Dr. Pat Gabby, Dr. Long and Dr. Allen had been sharing information with me for some time, but there's one moment that stands out to me as the moment where I, with great leaders in this community, needed to step up and do something about it. It was last summer, July 23rd. It was my daughter's 3rd birthday. And Dr. James was kind enough to put me at the beginning of an agenda and program over at the Lincoln Theater, where we were talking about the disparity with health, but particularly disparity amongst racial disparities amongst infants and young people in the state. He was kind enough to put me first on the agenda so I could take Claire for ice cream on her birthday. And as I left the theater that night, I realized that there were 150 fathers in this community that were never going to celebrate their children's first birthday, let alone their 3rd. We also have a significant challenge in this community that African American children are nearly 2.5 times more likely to die before they turn 1 than white children. We as a state rank 49th out of 50 in the United States of America. You're more likely, if you're black and under the age of 1, to die in the state of Ohio than nearly anywhere else in America. So, more babies are born in Franklin County than any other county in the state. So I committed to Dr. James and to the governor, to the mayor, and to our task force that Franklin County would lead the way. Just last week, the Columbus Dispatch published 3 obituaries of babies who died under the age of 1. When we launched the task force in November, I charged this esteemed group, which is led by Ohio's First Lady, Karen Kasich, as honorary co-chair, and Donna James and Mike Fiorelli. There are a number of members of the task force in the audience, and I would just like to introduce them. And if you'd hold your applause until I complete the list, I'd appreciate it. Donna James, Anthony Trotman. Yes, please stand. Donna James, Anthony Trotman, Yvonne Honeycutt, Commissioner John O'Grady, Judge Laurel Beatty, Janet Jackson, Nicole Dunn, obviously Dr. Long, Lori Barreras. I'm missing any of the other task force members? Please give them a round of applause and thank them for their service. This process has been a pretty amazing journey, I think, for all of us in deepening our understanding of the issues surrounding infant mortality. And we wouldn't have gotten this far without significant financial support, outstanding leadership from Donna and Michael and the First Lady, but also significant financial support from the City of Columbus, the County Commissioners, and the Columbus Foundation. The task force will be preparing its final report and recommendations and will be released on June 25th at 9 a.m. at Columbus Public Health, the intersection of Main and Parsons, and I would love to have you all join us. Our goal with these recommendations is to reduce infant mortality in this community by 40% and cut the racial disparity in half by 2020. That's our short-term goal. Our aspirational goal is that not even one death is acceptable in this community, and the racial disparity cannot stand. So with that, I want to open things up for a conversation with our esteemed panelists. And I'll start off with Dr. Long. Dr. Long and Dr. Allen from Children's Hospital helped to lead this effort. Dr. James and Dr. Gabby have served as our experts in residence, and Dr. Davies has helped to inform the process extensively with she and her great team of researchers at the Kirwan Institute. Dr. Long, we've said that infant mortality is an indicator of the overall health of the community. What do our rates tell us about our city's overall health?
Well, I guess you all know, perhaps. So first of all, thank you so much, President Ginther. To all of you, thank you for being here on a most important afternoon. And to the members of the task force, you and we have learned so much. Your commitment is inspiring. And frankly, I think as Council President Ginther says, this cannot stand. So to the extent that infant mortality is an indicator of a community's health, it's also an indicator of a nation's health. Our nation does not do well. Our state, as you've just heard, does very poorly. And indeed, our community is one of the top worst 15 in the nation. New York City's infant mortality rate is half that, actually less than half that of Columbus and Franklin County. So we know we can do better. We know we must do better. But as one of the task force members said, really our infants are the canary in the coal mine for the entire community. And that is what I think our task force has come to learn, that indeed the health of a mother, the health of a woman, the health of an infant is really much more than health care. And that indeed it reflects all of the social determinants, as we call them, the determinants of health, the social, the economic, the influences that a mother is facing throughout her pregnancy and frankly prior to her pregnancy. So again, the task force has learned that we need all of our women to be healthy before they become pregnant, because that, frankly, is probably even more important than the prenatal care that they receive. So it means, again, that yes, poor nutrition, the use of tobacco, alcohol, and drugs, those are critical, but even more critical are issues around poverty, around education, around housing, around safe neighborhoods, and around access to food. And yes, access to health care as well. So it is there where we see big disparities, where we know that, again, to be successful, we have to address these disparities. And these indeed reflect, and that's why it's such a good indicator of a community's well-being, is it reflects how well a community is acting and working together. So we know that it's more than healthcare. Otherwise, the rest of us, physicians and hospital leadership, we would have fixed this long ago. It really is about all of us, and that we have to both dig deep and look to how we can address those underlying social and economic factors that are crucial to good health and well-being. So the state of health here in Columbus, and using our infants as that canary, it's not so good. The good news is we know other communities have done this work. It's hard work. It will take all of us, and both transforming systems, working with individuals and relationships, but ultimately in how we change our community, support the well-being of women, of infants, and of all of the families here in Columbus and Franklin County.
Dr. James, when Teresa was speaking, it kind of reminded me, and I think folks got a little bit of a sampling of the makeup of the task force. But it was really important we were putting this together. To Teresa's point, this is not a health care crisis or problem. It is far more complex than that. Talk about your experience in successful cities across the country, but also why it was so important to make sure that the CEO of the United Way and the CEO of the health systems, the CEO of the Human Service Chamber, and representatives of government all were part of this task force process.
I think generally when we think about infant mortality, we usually think about it in clinical terms, so that the most common reasons that babies die during the first year of life have to do with things like being born too early, premature birth, congenital anomalies, sleep-related deaths, sudden unexpected infant deaths, etc. But that, from my perspective, is just the tip of the iceberg. I think internationally we've seen in most developed countries this movement over the last 15 to 20 years to the importance of addressing the social determinants of health as the most important influencers of health in general. So where we live, work, and play, the community's viability, its healthiness as a community are important things that make very significant contributors to, in this case, infant mortality. So part of what we're saying is that poverty contributes. Whether or not someone is successful in school and goes on to college contributes. The amount of crime in a neighborhood contributes. So that those social determinants are important pieces for us to address. And that gets to be very important then when we talk about how do we improve infant mortality, because we have to force ourselves to broaden the conversation beyond just talking to doctors and nurses and clinics and nurse midwives, that the conversation has to be carried to business, to public safety, to our education system. Within Region 6, perinatal Region 6 consists of perinatal Region 5 consists of 6 states in this part of the country: Ohio, Michigan, Indiana, Illinois, Wisconsin, and Minnesota. Minnesota, far and away, has the best infant mortality rate of those 6 states. When the 2012 data is released, will probably be within the best 5 nationally for overall infant mortality. But to assist in addressing and improving infant mortality even more in their state, Minnesota just passed a minimum wage law. Most people don't think about that as something that contributes to an increased rate at which babies die. They're working now to introduce legislation to improve their collection of race, ethnicity, and language data so that they can dive in deeper to understand much more clearly some of the disparities that occur within their state. Ohio hasn't gotten on that page yet, but it's a direction that we need to move in. As President Ginther said, by 2010 data, Ohio ranks number 47 of all states in the United States for infant mortality, number 38 of all states for white infant mortality, and we're next to the worst state in the nation for a black baby to be born. Yet we rank number 7 in terms of the number of babies delivered per state, meaning that we have this huge responsibility statewide to make sure that we're much more vigilant than we have been in terms of improving outcomes for our babies.
Dr. Davies, you've mapped our community in terms of our hotspots for infant mortality and how issues of poverty overlap. What aspect of that data and analysis has been most surprising or enlightening for you and your team?
Well, so the Kirwan Institute utilized data that we got from Columbus Public Health that ranged over a 5-year period. And that gave us information about every infant death that had occurred here in Franklin County over that period. And we were able, when we mapped that data and those deaths, to really see visually and to depict in what are heat maps, essentially, the hot spots of infant mortality here in Franklin County. And so what's most remarkable about that is that you could visually see the neighborhoods where most of these infant deaths are occurring, and you could visibly predict where it is that the neighborhoods are going to suffer the future deaths of babies in this community. So that's important because it enables us to be strategic in our interventions and the things that we could put into place here that can reduce and should reduce babies dying here. But when we looked at the neighborhoods, we were able to identify eight neighborhoods in particular that have enormously high infant mortality deaths, and these neighborhoods, it's important to know, have only 9% of the county's total population. Only 9% of our community lives in these 8 neighborhoods, yet these are the same neighborhoods where 22% of all the babies die and where 30% of all the non-white babies die in our community. So this enables us, by looking at this data, to be quite strategic about what it is that we do. We do need to focus on the women, the mothers, who live in these neighborhoods and the conditions that surround their lives. And that's why Dr. James and Dr. Long are talking about things like minimum wage and things like education. It's sometimes tempting to think about infant mortality or any aspect of health as a medical issue. And to focus on things like access to health care, access to prenatal care in this particular instance. And that's important, but it's not the only important thing. And really what these hotspots tell us is that we have to attend to the conditions that exist in these neighborhoods in order to have even a chance of reducing the racial gaps that exist in infant mortality in our community. Not one person in this room, I know, is content to live in a state where we can say that if you're an African American baby about to be born, almost the last place that you would want to be born is in the state of Ohio. None of us want to be able to say that. So we have to be able to use these heat maps, which the task force has been considering, to think about how we could strategically design our interventions to help future mothers and their babies.
So, Dr. Davies, what does life look like for the women in these neighborhoods, these 8 neighborhoods? Give us a sense of what women and families might face in these neighborhoods on a day-to-day basis.
Well, if you live in one of these neighborhoods, you would live in a neighborhood that is most likely going to have a number of vacant properties nearby. Vacant properties, we know, also attract higher crime rates. Additional enhanced exposure to violence in these, and all the stresses that go along with exposures to those kinds of things. These are neighborhoods where the families will be living in poverty disproportionately. They will be neighborhoods where the school systems are failing our children. and all the stresses on households that having children not doing well and progressing the way that we want will have on parents and caregivers in those households. These are households and neighborhoods where the unemployment rates, as was mentioned, would be significantly higher. Finding jobs, much more difficult. Likelihood of losing your job in a recession, much greater in these neighborhoods. So financial strains, food insecurity, living in substandard housing, all of that would be an aspect of the lives of the folks who are in the neighborhoods that we are describing as infant mortality hotspots.
So thinking about those indicators or conditions, Dr. Long, can you share with us a little bit about how those situations and environments impact the health of women and families in those neighborhoods based on that?
Thanks. So, thank you. No. Well, first of all, as far as how we think about this, and thanks to Dr. Davies Sharon for setting this up, we know that poverty and unemployment are associated with higher rates of infant death and infant mortality and lower rates of childhood success and educational attainment. We also know that this poverty and unemployment connection, also we see increased rates of unintended pregnancy. We see increased rates of repeated pregnancy and rapid pregnancy. That's not good for the health of women nor their infants. We also see less use of prenatal care, and actually we also see, and we know there are challenges around sleep-related infant deaths. Moms and families may not have access to, and we can talk more about it, to both the knowledge, but really a crib. So picture this as far as this connection between health and poverty. If you're an adult, a single-headed household, I'll start there, and you have two kids, one who's in preschool and one who is an infant. It's pretty hard to get by in our town. We've looked at the American Community Survey. We matched that with the Self-Sufficiency Index for Columbus. What would that require you? It would require you to have $791 in your pocket every month for housing, an additional $1,700 for childcare, $445 for food, transportation, $270, health care, and other $350. All told, your math is good, but not that fast probably. This would take you to a minimum wage of $26.39 an hour. So picture that. That's 3 times the minimum wage here in the state of Ohio. And this is not an uncommon picture. That's a salary of more than $55,000 a year. And that's to be minimally self-sufficient. If you happen to have 2 adults in the household, which that actually, you have a few more increased expenses, but it does lower the required salary to be self-sufficient to $14.86 an hour, which again is nearly double the minimum wage. So again, as we've talked about this link between poverty and health and well-being and the choice of neighborhood and schools, et cetera, there is no doubt that there are many in our community that are definitely challenged by these issues. Well, let me just also note that it's not just poverty, and we've been talking about the white and black disparity. These issues, and obviously they're stressful, or at least I think you'll join me in believing that what I've just outlined would be stressful. But indeed, we know that for every income level, for every education level, there remains a black-white disparity. So for college-educated, professional African-American women, their infants die at a significantly higher rate than their white counterparts. So again, there is stress. These are issues that we have actually talked about in the task force connected to how our systems have historically and currently functioned. So some of the isms, obviously, along the way, and we can go into those if you like, but clearly those have to be a part of what we are also addressing in this work.
Dr. James, you've worked on this issue in other communities and have a statewide and a national perspective. How many cities, many with even greater poverty rates, larger, even more diverse, have addressed this crisis. We've heard through this process from folks from Baltimore, I think Boston, New York City, other places around the country. And how does Columbus compare to some of those cities that are just starting this process or that have been working on this, in some cases, for 15 or 20 years?
Yeah, I think Columbus is part of a growing trend of cities that are grappling with taking much more ownership for this as an issue. And I think it started back when Dr. Satcher made the challenge to the nation in his Healthy People 2010 goals, where he suggested that he wanted to eliminate racial disparities in health outcomes in 6 healthcare areas, one of which was infant mortality. And a lot of people thought, he was crazy to make that suggestion. But over the next 10 years, despite 9/11, despite a substantially worsening economy, despite a lack of support from much of our national leadership, we in fact decreased the racial disparity in birth outcomes in that decade more than we did in the decade that followed the enactment of the Civil Rights Act. So that there is, in my opinion, significant credibility in not just a conversation about doing the work that's necessary to achieve equity in birth outcomes, but also taking a social determinants life course perspective as we attempt to accomplish it. So you are correct. Boston, Baltimore, Harlem, Oakland, there are even significant efforts right now going on in New Orleans. There are a lot of cities that are taking this on. There's several important elements to this work, but one of the most important, in my opinion, is that local communities have to take ownership for this. This is not something that Columbus has the luxury of sitting back and waiting for the Ohio Department of Health to fix for us. It's not something that we have the luxury of sitting back and waiting for our state legislators to fix for us. The perspective we have to take is that these are our babies and that they deserve better by us, that we have to step up and do better. From a state's perspective, what we suggest to folks regularly is that every baby matters. Black, white, rich, poor, Republican or Democrat, from a family that's right to life or pro-choice, legal immigrant or not, that any baby who is born and takes his or her first breath in the state, within the state of Ohio, is our responsibility, and we have to do better by those babies.
Dr. Davies, you and your team have really helped to inform our thinking and process. I think when we started this, we were clumsily talking about zip codes, but really we're talking about neighborhoods. And to Dr. James's point, what has the data and research told you about why it's so critical that the strategies and the success lies in this being owned and driven at the neighborhood level based on the data you've seen?
Yeah, well, it's because we're able to see how concentrated and how localized a lot of the infant mortality gap really is. And we are able to look at the conditions that exist in those neighborhoods that show up in lots of work being done in this community. In a way, you could associate what we're working on now with infant mortality to the work that was done just last year by the Education Commission, because we were focusing on the same neighborhoods. And if we focused on public safety and exposure to violence in our city, or vacant properties and the problems that instills, we'd be focusing on the same neighborhoods. We'd be working on the same issues. And so, in some ways, we think, oh boy, neighborhoods. We have to do more than just make sure that pregnant women get prenatal care, prenatal supplements. We have to really put so many resources into neighborhoods. See, the answer is that we're not actually very good at math sometimes because we don't realize how much we already are spending. We're just spending it on failure. Some of you may have remember Jeff Canada saying that when he was here, the president of the Harlem Children's Zone. And so what we really need to know is that investments that we make on community and neighborhood health, targeted investments, will pay many dividends, not just in the area of infant mortality, but in improved educational outcomes and improved health outcomes in other aspects too, improved life expectancies, improved productivity that comes from all of that. And so all of these things are intimately connected, and that's why my friends on the panel are talking about this as a system of conditions. And we have to look at it that way, and we have to approach it that way.
Dr. Davies makes a great point. I mean, infant mortality captures whether or not children live to their first birthday. What that doesn't measure is that children that are born premature or have other challenges when being born, the impact developmentally and otherwise, whether it's mental, behavioral, social, developmental impact of children, even if they make it to their first birthday, if they don't have the intervention and services they need at an early age and supporting mom and family, that impacts far more than just your infant mortality rates. Dr. Long, you're probably of this group closest to the women and children that are in our clinics and on the front lines of receiving health care in this community. Speak a little bit, Dr. Davies talked a little bit about what a day in a life would look like. Any additional insight you can offer based on women and children you run into in our clinics?
So we see women and children with all sorts of challenges every day. And indeed, we talk to women and their other supporters about sleeping their infants safely. As Dr. James suggested, that's the third leading cause of infant death in our community. And so when we talk to them about sleeping their child alone on its back in a crib, they don't have a crib. So indeed, we have come to learn this, and so there is an effort that's just beginning to both work with hospitals and others to see that every infant has a crib or has at least a safe place to live or to sleep, and that we're able to address that. But we have to also help them know how. We've told the story before of finding a terribly challenged family, and the pack and play had never been opened. So again, it's taking all of those steps. We do know and shared a story about a young woman and her infant that was looked terrible at a WIC clinic. And what came out after she had been rushed to the hospital, the mom with her infant who had nearly died, was that she did not have sufficient resource for food, and she had been diluting her infant's formula for the past several weeks. And so this infant was fortunately close to dying, but did not pass away. And then another vignette, because I think it shows to me how close we all are. We had a story recently of a college-educated, middle-class working mom, had lived in a suburban home. She worked at a local bank, and then she got laid off. So that sudden financial challenge to the family actually had some impacts, but it also increased the temper issues that her husband had. And he became violent towards her increasingly. And so she left at the same time realizing she was pregnant with her third child. So she, of course, tried to live with other family members and friends and bounced around, and that was very hard. Ended up in a family and a homeless shelter. She couldn't get the money together for rent. She was all of a sudden in a system, or maybe a lack of a system, that was so foreign to her. And so indeed, she was struggling to get a bank account. She was struggling. She didn't have a cell phone. So she was trying to find work. And of course, embarrassed about her situation, but she too was struggling with trying to feed her children, trying to get access, and then keep going to prenatal care appointments. So again, I think part of this lets us know how close so many of us are. It may be one paycheck, 2 or 3 paychecks, and also the stress of all of this obviously brings out other parts of our lives. So again, it's about supporting all of us and systems. And again, the task force has learned, and I think considered this when it came up, that our community is program rich, but are we system poor? And frankly, I think the task force grappled with this thought and said, we need to be about system change.
So we're approaching the time where we'll take questions from the audience, as is tradition with the Metropolitan Club. So be thinking of questions and making your way to the microphone there to ask your questions of the panelists. I guess the one question that I'll wrap up this discussion about is, so Dr. James, have I lost my mind? Have I charged this task force? We've heard from national experts that this is one of the most bold, ambitious goals in the country to reduce the overall infant mortality rate by 40%, cut the racial disparity in half. Reassure me this is doable.
With a lot of work, substantial community support, this can be done. But please understand, as President Ginther has just mentioned, this is an exceptionally bold challenge to the community. During one of the task force's initial meetings, I had an opportunity to address the task force, and part of my comments were, how cool is this, that Columbus is willing to take this on, despite how gargantuan the task seems to be. When you think of it, at least when I think of it, from the perspectives that to not do something that in a bold way is different is to continue to suggest that it's okay for babies to die at the rate that they're dying in our community. And I think we would all suggest that that's not okay. So that if we get to that point, that it's not okay, then we also have to be willing to take the steps necessary to change the way that things are here now, so that that situation is very, very different for our babies 10 years from now.
Thank you. If you would just share your name and ask your question, feel free.
Good afternoon. Greg Brown with the Graham Family Schools. We are a group of 4 charter schools in Columbus, 2 high schools, middle and elementary. And I hear you mention education a lot, which I appreciate. And we have a lot to do from our own end to help increase achievement for kids. But my question is about alignment. We have huge resources through public education. We encounter tens of thousands of families. We also have hundreds of buildings. I'm wondering how we might get the resources from your end up there at the panel, and thank you so much for all that you're doing, into our schools, working with our families and our kids, helping us to educate them on these issues, and how we might use the buildings better. I can't offer up any except our own schools, but we have 1,000 kids and 3 buildings, and I would welcome a discussion on how we can best use them. So thanks.
Thank you.
Please. If I could take a stab at that, I love the question. It's so important, and it's related to what Teresa was meaning when she said we may be systems poor, program rich, but systems poor. So one of the things that the Kirwan Institute is trying to map next for the task force is how many programs and assets really exist here in the county. We actually have a preliminary sense that there are a lot. We don't have a full sense because no one's ever actively collected data about them and then mapped them. But once we have that done, we need a much more coordinated system and networking between the programs and their directors than we have in place right now. This is what United Way means when it talks a lot about collective impact. We can only have collective impact if we are utilizing the assets that our community actually has in place. But right now, so many of those programs are operating in siloed ways, and so we're not leveraging the assets that we have.
Any other thoughts on Greg's question?
I'd love to jump in there as well, because clearly the schools are both trusted neighborhood locations that are both serving children but could serve families in lots of different ways. So we've had an interest at Columbus Public Health. I think it's growing. How could we get, and it wouldn't just be us, obviously we would have to bring more programming in, but support them in being centers for active living. You know, could we teach cooking classes? Could we have, if we can't teach sex education or health education and personal empowerment and good decision making during the school day, which could be talked about, but how could we do it in the afternoons? And could we make them be safe places of refuge in lots of different ways? And actually, just prior to this, we were meeting, my lead team, were meeting with the new Director of Education for the City of Columbus and her whole team, and we just learned that there's actually a bill going through the State House right now that would release the schools of some of the liability issues that have been apparently a hang-up to allowing school facilities to be used in these more community-oriented ways. So again, we would welcome the opportunity to think about how can we turn them into centers of continued education, of continued workforce development opportunities, but obviously for health and wellness as well.
Yeah, and I'd also like to add that, you know, when we look at this data, one of the questions that regularly gets posed is that, well, how did Ohio get to be where it is? How did we get to be so bad in terms of infant mortality? And some of the reasons have to do with policies that we've had on the books that actually place families at increased risk for poor birth outcome. That we just this year are getting to the point of offering presumptive eligibility to pregnant women when in fact it's been available nationally since 1986. The same with offering a modified form of Medicaid to pay for contraception. We just offered that in our state in January of 2012, again available since 1986. What does any of that have to do with your question? Well, one of the other areas that the state of Ohio, not just Columbus, has struggled is in its whole sex ed curriculum. And teen pregnancies are a challenge for us. And unfortunately, teenagers who get pregnant have a higher infant mortality rate. So while how cool would it be if we could collaboratively work together, align our interests, but that word collaboration is a challenge. And one place I went, I heard a national speaker define collaboration as a unnatural act performed by non-consenting adults. And sometimes that's the way that it feels. But we don't get this done if we don't figure out a way to have collective impact, to work together, because alone there is no single organization in this community that has the resources necessary to accomplish the change that we want to accomplish.
Next question.
Rebecca Asmo with the Boys and Girls Clubs of Columbus. One thing that I and our staff have personally seen that's been very troubling to us recently is we've had several teen mothers just over the past few months who have been referred to our program. And one thing that each of these mothers has in common is that they told us that they've been encouraged to withdraw from school by actually administrators in their school and enroll in either an online school or an online credit recovery program. And so when we see these young mothers, they're very disconnected from any kind of community and really have trouble accessing resources. So while my experience and our staff's experience may be anecdotal, have you seen this to be true? And, is there anything being considered by the task force to address, marginalization that teen mothers or any mothers might experience? Thank you.
And, this onslaught of online access thought to be more convenient and conducive, but does it contribute to isolation and withdrawal, particularly for younger women?
So one of the things that we've done at Nationwide Children's is to begin a program to provide prenatal care to teens. I'm going to suggest to you that in clinical terms, the prenatal care that we offer at Nationwide Children's isn't any better, isn't any different than anyone offers anyplace else. But the difference is that we attempt to offer this prenatal care to teens in a setting designed for teens. And we do it with a gargantuan amount of social support, because much of what makes pregnancies high risk to teenagers is not so much the clinical stuff, but it's all the non-clinical stuff that you've heard us talk about here that teens often have to deal with. And I have to tell you that in Columbus, more than any other community that I've been in, I have seen exactly what you have referred to, where there has been this notion that somehow it's beneficial to the teenager, that she doesn't have to walk up a couple of flights of stairs, or she doesn't have to change classes, that those things are somehow so stressful on her pregnancy that it's more beneficial for her to stay at home and study rather than to go to school. I don't know of any study that's been done that suggests that. But I do get concerned that it is a mechanism of marginalization, and that we need to conduct that study to see what happens with those teens. It is not, and I'm going to underscore that, it is not my impression that they matriculate at a greater rate than teens who stay engaged in school or involved with their peers. But that's something that we have to find out, because this whole movement toward homeschooling is new enough that I don't think, at least I don't have the information to really answer your question.
I know that we have 2 questions left in about 4 minutes, so I'm wondering, Andy, should we do the rapid fire and have each question asked and then have folks respond? If you share your name and your question, and we'll give everybody a shot at it.
Hi, I'm Eric Davies. My business is Transformative Consulting, which works a lot with the inner city and rural community health center programs in Ohio, including here in Franklin County. And my question is, and I guess first just I appreciate Dr. Long for so many years talking about the social determinants in Franklin County and just in general in areas of poverty. 2 that I thought were missing also related to physical activity in the built environment, and also just the other half of the equation, that when you have single moms, you also have absent fathers and absent men, and many young, frustrated and challenged men who are impregnating women. So one of the things that I wonder if ties it together is also social isolation. And social isolation is very disempowering, and connection is very empowering. So do we need to take a systemic approach to social isolation?
Our final question, and then I'll give the panel a shot at answering both of them.
Thank you. My name is Sherry Jones with Measurement Resources Company, and I really appreciate the discussion about systems change and collective impact. And a lot of communities have found success looking at the bright spots, studying the bright spots, and what, how are those that are working well, what makes them work well, versus kind of focusing on the negative and the things that aren't working. And I wondered what efforts have been done in this community to really study the bright spots in the community and not just focus on the negatives.
Thank you.
So let me tackle that second question first. And if I look at it just in terms of infant mortality, obviously our white infant mortality is better than our black infant mortality. We've heard President Ginther say that black babies in our community die at 2.5 times the rate of white babies. But a big piece of what you need to understand in terms of this transformation that we're trying to bring about is our white infant mortality in Franklin County and in Columbus is way too high. So we can look at our white infant mortality as a bright spot and try to emulate some of the things that are going on there. But the white infant mortality rate in Franklin County is not our end goal. We want everybody's infant mortality rate across the board to get better. We believe we can do that because so many other cities have. And because we have all of the stuff here to make it better, to create the kind of change that we want to create. And I don't know that I necessarily think that focusing in on what's concerning about our neighborhoods means that we're only focusing in on the negative. I think that the way that we want to transform those neighborhoods is in a sense to have them look more like the neighborhoods who don't represent the hot spots. So in that way, we do see some positives that we would like to emulate in terms of the social determinants perspective. There is also the international data that suggests to us that when we take a social determinants perspective, that everybody's rates improve, that it's not just the people who are doing the worst, because we have this gradient that we've created, that the wealthy do better than the middle class and everybody does better than the folks who are poor. But when we take a social determinants perspective, we get closer. We never get to the point that everybody's doing the same. But instead of having a gradient that's like that, it's more egalitarian, if you will. And that's part of what we would like to achieve.
Can I just... Oh, thanks. So thanks, Art, because it's pretty hard sometimes to lift ourselves up to say there are bright spots. But indeed, as Dr. James said, there are some bright spots. And you may not be aware, but our Hispanic community actually does better than our white community, and actually one of the most interesting communities that we're really trying to better understand through data, but I know anecdotally, is our Somalian community. So in speaking to our Somalian staff, it is no doubt that they have strong family connections, they have strong support systems, and so indeed, I think there are some key lessons to be learned about, and someone mentioned earlier, about relationships, about supportive systems, about the strengths in neighborhoods and in families. These are bright spots that we need to both understand, but try and move further in our community.
Carol, turn things over to you.
Actually, if you want to give Sharon one more chance at this, and then we'll end.
Yeah, well, I would say that one of our greatest assets, community assets, that we should really recognize is Dr. Arthur James, who not all of us in this county recognize as one of the nation's leading voices on infant mortality. And also a fabulous program that has been put into place now in a number of neighborhoods around Columbus, the Moms to Be program of Dr. Pat Gabby. Just a fabulous place-based intervention, supportive, holistic thinking system. So we have wonderful people and a task force that is studying this. We have a lot of things that are working correctly with our community, and that bode well for us. But we do need to be quite deliberate and strategic about what it is that we do to eliminate these gaps and to reduce the size of the infant mortality rates in the state of Ohio and move us from 49th worst to, I would say, the best. That's our goal.
I hope you enjoyed today's forum. We encourage you to continue this conversation in the lobby over coffee and cookies. It's a very important conversation, and I hope our speakers will be able to stay a few minutes longer. Remember, you can view and share all of our forums on Columbus TV Channel 3, statewide on WOSU through the Ohio channel, and anytime on CMC's website via YouTube. Once more, thanks to National Church Residencies and all of our other sponsors. And let's thank our speakers, Andy Ginther, Sharon Davis, Teresa Long, and Arthur James.